Good evening. My name is Andrew Goodeill. I'm working with a group called Foot and Ankle Surgical Associates. We have several offices. Let me backtrack. I'm a podiatrist, and so the title here, Podiatry Examination and Treatment Approaches. Some of this is going to just be about what we do as podiatrists, but also when we feel like it's time to refer out, or when we might even want something referred to us, and kind of just an overall view on kind of how we approach things, and honestly, how I approach things. So again, I work for a small practice. It's actually a large practice, but it's a private practice. It's not for a hospital. Foot and Ankle Surgical Associates. We have offices in Tacoma, Olympia, Lacey, Tumwater, and Centralia. We have been out here in the Elma area before through different reasons or whatnot. So it's not what's happening now, but coming back into the Tumwater area and some of the other practices, we see a lot of Summit patients out there. So just a little overview of kind of who I am and where I'm coming from. There we go. Okay, so some of even coming up through podiatry, we've got the private practice, we've got hospitals, we've got this, but we've got where we refer everywhere, right? I refer to hospitals, I refer to other private specialties, and then we get referrals. And some of this is just that I've encountered in podiatry is this way a lot, where we're sending to vascular, we're sending to ortho if there's something else, we're sending back over to infectious disease, right? So just this black bag doctor that does everything. There are people that do a lot. I don't mean that, but what I mean is that we have teams. We're all together now, right? Is that if I've got a problem with a wound and it's not healing after a little while, I get vascular involved to find out if this is some of my problem, and they know that tenfold better than I do, right? And so I might have some knowledge, but getting out there and making sure that we're getting to our patients to the right people, so that the goal is to be healed, not I heal them, right? So I don't care who does it, just let's get it done. So just the different diagnostic imaging and procedural referrals, whether it's MRIs, CTs, whether it's ultrasounds, different referrals coming from primary, like PCPs, where some of them can't come from me because of insurances. So it's got to go back to the PCP, then go back out again. And if I'm giving those out, it's just slowing the process down. So kind of knowing some of those, that I can do it with this insurance, but not that insurance. And so some of that in the private world really does slow things down. Yeah. And I think that sometimes I've run into some specialties where, they kind of want, and you can have the patients, because any overlap to me is just more care for the patient. And so it's just more about getting patients to where they need to get to, so we can all help them at the same time. So when I'm doing a vascular just workup, and new patient comes in, I'm feeling and I'm grabbing pulses. We've got Dopplers if we need to, right? But then a lot of that, I'll go right to an ABI, and some of that is giving me a numerical value then that I can either convey to the patient. Let's just monitor this for a few months and kind of check back. Let's get you to vascular, and let's get an ultrasound, because we're not getting enough blood flow, or there's looking like there's some obstruction. So some of this is not only just assessing it, but being able to see, again, who and why I'm going to send them there. I'm checking temperature. I'm checking for the color, absence of hair, and then using different values, right? So, and I talk to patients too, even when they're in the middle where I don't need to refer necessarily. If they're lower in the 0.8s, then I'm letting them know, once we get you here, we might not have enough blood flow for healing and different things. And so just even educating them, right? Why am I doing this? Instead of just running a test, it's knowing what I'm going to do with it afterwards. When they're elevated, we're getting enough blood flow, but it's working a little bit harder to get there. So let's see if there's something that a different specialty has that can give me some blood flow a little bit better. And the same thing I was saying a little bit earlier is just with wounds. If there's 2 visits and the wound isn't improving, I would rather an ultrasound instead of just using blood pressure cuffs and an ABI. Give me a little bit more detail so we can find out if there's something else that can be done. Dermatology, again, just kind of running through things as I'm seeing a new patient. And, a lot of what I'm seeing is diabetics or peripheral arterial disease. I see a lot of patients that are 65 and older that are having swelling, and they're having skin changes, and they have vascular changes. And there's a lot of different things where somebody comes in saying, I have a callus or a hyperkeratotic lesion. If there's bleeding underneath there's a good chance that there's injury to the subcutaneous tissue. And I take down a lot of calluses that turn into a wound. It was already a wound, it's just showing bleeding underneath. And so that's one of the other things that I talk to patients about, is just getting, if you see bleeding underneath the callus, come in and just let me tell you it's not anything. So we don't wait 9 weeks because of Medicare's rule, and then we find out it's a wound. Because it's about, as soon as those are open, the faster we get to them, the easier it is. Making sure it's stable from infection, blood flow, and just assessing, is this a dry wound? Do I need some hydrogel? Is it a moist wound that I'm going to get some betadine, some different type of dressings? Biopsies are helpful. When I think anything is cancerous, typically at that point, I'm just going to refer you out to the oncology specialist in dermatology. I feel like letting them get the borders that need to the complete borders that need to be gotten. And again, that's just where I go back to, somebody does that more than I do. Somebody get them over there and make sure we don't have anything cancerous. Rashes, a lot of times it is an antifungal or a steroid or a combination of the two. And the other part is, if it's not working, biopsy. You can even do just little skin shavings if it's even just a tinea pedis, which is like your athlete's foot, your typical athlete's foot. Or I'll ask derm, what's going on? I get a lot from derm too, where they're like, we've tried this, we've tried that. How about you try something? And there's different ways that warts can be done with the canthrone or freezing or even excision. So just different ways that dermatology might do things versus the way that podiatry might do things, that we kind of go back and forth as well. Going back to seeing a lot of diabetic patients, it's more and more, there's more neuropathy that is not diabetic related than what there used to be. There's still the consistent diabetic neuropathy, but now there's a bunch of idiopathic. We've got chemotherapy reasons, right? And so it's about helping them feel better. If there's numbness, trying to get some more sensation. If there is pain, trying to kind of bring those signals down, whether it's through supplements or gabapentin, Lyrica. I typically start pretty easy on just supplements. Most of the time, I can get a little bit of relief, and that's what we're looking for. I'm letting them know that I can't fix it. There's not going to be something we can do. If it's a diabetic, I definitely talk to them about controlling their diabetes and bringing down their HbA1c and what that could do for it, but also letting them know that it's not a cure. We're not trying to cure it. We're trying to make sure they're comfortable. If it's sleep, the weighted blanket, different supplements. And a lot of times when the nerves are overactive at night, we're trying to go to sleep, our minds are resting, the nerves are not. It's where the weighted blanket or just even a low dose gabapentin would just help somebody sleep. And a lot of times then some of those nerves are not as on fire the next day, and they don't quite always need, not every patient, some of them do need the 3 times a day gabapentin. And that's just usually where I start them out and see if we can get some relief before it goes. Capsaicin cream, I feel like it has its place. There's a lot of patients that don't find a ton of relief, but weirdly, when somebody does, they find quite a bit of it. The Qutenza patch is a beefed up version of that, where it's a much higher concentrate that sits on the patient's foot. It almost looks like saran wrap, and it's wrapped around the foot for 30 minutes. A tight either ACE wrap or Coban is wrapped around it, and it's absorbed into the skin, and it gets them up to 30 to 90 days of relief. Now, most of the time, that is going to require somebody who is already getting some relief from capsaicin, and in my experience, it's less than 50%. There's not I don't know the population specifically, as in like studies wise, but the idea that it's not just every diabetic or everybody who has painful tingling, it's kind of hit or miss. But that has been a newer treatment that I've used this year as well.
That's amazing. You're on to something.
When it comes to the ortho side of things, we get a lot of patients coming in with either bony or soft tissue issues, whether it's deformities or gait abnormalities, whether it's somebody that was born with these deformities and or that we kind of give to ourselves, whether it's shoe wear, our activities, the ground and pound, somebody's foot who's been in the military running PT every day looks a little bit different than somebody who's been sitting at a desk and not doing a lot. And so it's just kind of the way that we acquire things versus if we were born with them. And so a lot of times it's just even going to the approach of x-rays and kind of seeing where we're at. I get bilateral x-rays every time unless somebody really doesn't want me to for radiation reasons, which it's a very low dose towards the foot. It's not something that I'm concerned about. If somebody is, that's okay. I don't need to, but even a lot of times I'll say, can I just get it so I can look at it? I don't need to bill for it. That's not the reason. The reason is so that I can see if it's different, the same. A bipartite sesamoid on one side might be a fracture on the other. It's just different comparison views. And so sometimes people get upset about that, but it is really helpful in diagnosing and being able to say, look, you have the same thing over here, over there. The reason I even have this picture up is because I use the bilateral piece a lot because I have a ton of people that come in and say, I have heel spurs. It tells me something, but most of the time they have a heel spur on the other side too that they don't have pain on, which means it's not the heel spur that's causing the problem. It's actually the tissue around it, right? And so I use that so that I don't hear every 2 weeks, but what about my heel spur? What about my heel spur? We can get rid of your pain and your inflammation without dealing with the heel spur. There may come a time that we do deal with it, but most of that is going to be about releasing any adhesions to it and less about lopping it off with a chisel or something like that, right? Which I think a lot of times that's what people think is going to be done, and that has been done. And it's been helpful in that moment, but knowing that you actually had to get through the soft tissue to get to that bone spur is one of the contributing factors to that surgery being effective anyway. Just a point to why I get bilateral x-rays. It helps explain things to patients on why it's there and why it is not the sole reason that you're having pain, but let's get a different device like an ultrasound to show the thickness and kind of see what we're dealing with. I'm also looking for fractures, dislocations, but also just if they're having pain on the inside or medial side of their foot, is there some type of deformity, valgus, which is more of the flat foot, or cavus, which is more of the varus foot? Is that contributing to what they're having? Somebody might have calluses, but it has to do with their cavus foot type that is really high, and so they only have 2 points of contact, which is the heel and then the ball of the foot. And so some of these are helpful even for my knowledge, but also, again, to educate the patient that this is why I want you to have an arch support, because now we have points of contact throughout the arch and not just in 2 different spots. And so I like to use x-rays to educate on why I'm doing a lot of things as well. I think that's helpful instead of just getting them and not telling the patient what we're doing them for. And then obviously the bunions, hammer toes, and we already talked about the heel spur there, but some of the things that we see, plantar fasciitis, which, a lot of times people ask me how you got it. You can get it just from walking. You can get it from a bad pair of shoes. You can get it from, a fall or jump from something. Just point being is that there's not, unless you know exactly what you did when it kind of pulled, it's usually just a overuse and or lack of stretching, tightness, different things that contribute to it, but it's not one of those that you can always just pinpoint, this is when it happened, this is why. But everybody wants to know why. Everybody definitely does. But the flat feet, the high arch, a neuroma, which is nerve irritation of the foot, it can cause pain and tingling to the toes, metatarsalgia, pain to essentially the metatarsal heads, and they can happen. A lot of these happen at the same time. Achilles tendonitis and plantar fasciitis are closely related. You've got your bunions and then different tendonitis and hammer toes, and kind of the pain in the ball of the foot. And I'll just kind of walk through a few of these and how we approach those and how I think a lot of times people don't realize that they have these situations. It's just pain that they've dealt with. I get a lot of patients that come in and say, I felt this way for 2 years. A lot of times things can kind of ebb and flow based off of activity and shoe wear, but if it's been there and it's not getting better after a 3 to 6 month time frame, I'd go in and get seen and see if there's something that can be done to help. Sometimes it's just changing our shoes, and sometimes it's a little bit more than that. So a plantar fasciitis or heel pain, you can have plantar fasciitis and it not be in the heel. A lot of times the plantar fascia runs completely underneath the bottom of the foot, so it originates at the heel, but you can have it in the arch, you can have it distally towards the metatarsal heads. Typically, I will, when we're measuring the plantar fascia, I want that between 2 and 3 millimeters of thickness. Once we're getting over that 3 to 3.5, somebody's usually starting to feel some of that bruisey type pain, and I hear they kind of just want to stamp it out kind of thing. Icing, stretching at that point would be suffice, and probably change or arch support or change of shoe wear. Once the plantar fascia gets over 4 millimeters, I try and talk somebody into injections. The reason being that you can't take a pill and say, go to my right heel. It can't happen. And so most of the time somebody takes an Advil, it kind of helps that day, and 3 days later they take it again. And so they're not even taking it consistently enough to actually affect what is the inflammation of the plantar fascia. And so I can use the ultrasound and target exactly where it's at. And then we're able to kind of shrink what's there. And so differently, instead of just, giving the injection, but being able to show them where it's at, how it's working, and medicine being dropped in, I think is also helpful. Prefabs are just prefabricated orthotics. They're they're over the counter. You can order them from Amazon. You can go to your pharmacy. We have a version in the office. You want something to be semi-rigid. If it's just soft, that feels good for a little while, but it's actually not support. You're just adding some more bulk to your shoe wear, actually. And so you want something to, when you push down on it, that it kind of rebounds. And so it's actually supporting that arch area. And so I will start them off with some prefabs, a steroid injection, icing and stretching instructions. A night splint is something used to stretch throughout the night. I never make anybody sleep in it because there's no way I could sleep in that thing. They look like a cam boot without the front, and they keep your foot at a 90-degree position to your leg. And so it's helping stretch your Achilles, your plantar fascia. A lot of times patients will get kind of cramping or something like that overnight and end up taking it off. The reason for it being worn overnight is that first step in the morning, where the plantar fascia is painful, it's tight, it needs activated. And so a lot of times I just have a patient use it for about an hour at night, wake up in the morning, and use it for about 20 minutes in the morning before you get going, and really get that area stretched out and activated, get some blood flow down there. I see patients back about every 3 weeks, intending on doing more injections. And some of that is we are going to walk on and use whatever is injured for that entire 3-week process, right? And I've been doing this a large portion of my life, but long enough to know that most people in that 3-week time frame will do something that will aggravate it, whether it's shoe wear, whether it's walking around on hard surfaces without shoe wear, whether it's an activity. And so knowing that if we're getting 1 millimeter per injection, we're getting ourselves right where we need to be, kind of that goal of it. Once I've gotten to that 3rd steroid injection, we talk about PRP, which is platelet-rich plasma. It's something that it's a lot longer process that we use the body's blood, spin it down, and we'll take the plasma, and we can inject it right back in. We're kind of tricking the body a little bit and taking what we would normally use for cut injury, and we're putting a big concentrate right back where we need it. So, and then after that, there's always surgery. But again, I try and exhaust all these processes. A lot of times PT is really helpful right in the middle there and or towards the end. It's hard in the beginning because it kind of aggravates things. And so I kind of try and calm it down before I send them to PT. Neuroma, bursitis, metatarsalgia, they kind of all go together. Most of the time, if somebody has pain at the metatarsal heads, that there is some type of bursa or neuroma. Not always is there both the neuroma and the bursitis. I'll get MRIs and there'll be a neuroma in 2 of the interspaces and a bursitis in a different one. A lot of times there's a lot going on at that ball of the foot. It tends to be the high arched foot or somebody who wears tighter shoes. If anybody was to really look down at their shoes, my guess is it kind of comes to a point. Most shoes do. But then look at your foot. It becomes wider as we come out. Most shoes are made because of the aesthetically pleasing look that we like in society or whoever likes that style of shoe. There's times that I'll put a patient on the x-ray machine with their shoes on and let them see what they're doing to their toes and their metatarsals. If you grab these metatarsals and put them together and all day they're shifting and moving, eventually a bursa can be formed and then a bursitis can be formed. And so sometimes it's just about, wearing a dress shoe all day when maybe it could have been a sneaker for part of the day and getting the dress shoe when you need to. And so for me, it's just even making those adjustments that not every foot type is meant for every shoe wear, but not every shoe wear is meant for every activity. We put on our shoes in the morning and then we go out and do whatever. And it might be that if we're going to walk around Costco for 3 hours, that we grab a sneaker and then we have our dress shoes if we're going somewhere else afterwards. just little adjustments like that keep us from injections, surgery, and all those things like that. And sometimes it's convenience or thinking of it ahead of time, but it keeps us from a lot of the other things. Again, I'll go to the steroid injections, ultrasound guidance, which helps get it where we need it to be. I'll try to get somebody in wider shoes. Off in both, in all of these conditions, if there's pain already, I try to get somebody off the hard surfaces. We've got man-made surfaces that essentially are kind of pushing back up against us. They're not giving it all. Just a flip-flop, a Birkenstock, a bionic, something in the house that can take the pressure off of it so it's not being exacerbated or made worse. And then eventually we might need an MRI for alcohol sclerosing injections, PRP, and then also surgery to remove that neuroma bursitis. The alcohol sclerosing injections are specifically for the neuroma to essentially burn the nerve so it's not giving you those signals. You get the same results. If it works, you get the same results as removing it. You get some numbness to that nerve. It's not giving that same signal anymore. They're painful. I haven't had one, but when my patients get them, they don't like them. But for some reason, there's always somebody that wants them. And you need about 5 to 6 in a row, sometimes more than that. But again, you're trying to kind of burn that nerve out so it's not giving you that signal that's really painful.
And you're talking about the neuroma?
Yes.
So it's a nerve in there.
Correct.
It's causing all this pain and trouble.
Correct.
And it can be cut out.
It can be. Yep.
Oh.
So if you're looking at the foot, kind of the metatarsal head area, they usually kind of sit here or up by the toes. And so small little incisions made, and you'll be able to follow the healthy nerve to a big clump of fibrous nerve that just looks angry and it gets cut out. The stump gets cut back as far back and into the muscle belly, and you typically will have numbness to those.
Now, are those caused from neuropathy?
I would say differently that's a type of neuropathy because it's the fibrous nerve is a specific neuropathy, but it's not normally caused by neuropathy. This is more caused by injury, shoe wear. There are even different dressings and wraps that can kind of contribute to this. There are patients that have gone in for surgery, come out of a cast, and now they've got a neuroma. The nerve was in there being irritated enough, and there was enough swelling in the foot, and so there's different cause, but at the same time, it can just be walking, right? And so somebody who just walks a little bit during the day, it doesn't have to be somebody that walks a mile or 2 miles. So there's a lot of different ways. But like I don't know if you were asking this, but like neuropathy isn't where I'm going to find a nerve in there that needs to be just removed and it would start to feel better or anything like that, but more of the sensation being out of proportion, but less, say, inflamed, if you will.
Gotcha. Makes sense.
Achilles tendonitis, very much related with plantar fasciitis. Everything's kind of interconnected, that back of the heel all the way to the bottom. If somebody's just having a little pain to the back there, I definitely like to just start with a heel lift and tell them to, again, find a sandal at home. As soon as you put that foot all the way down, the Achilles is pulled at its most top position. And typically when there's pain at that insertional point, it's because it's too tight. And so we need to stretch, but if it's so painful back there that every time you stretch, it's more painful, get you in a heel lift and kind of get that pressure off of that heel for 2 to 3 weeks. And then we can start stretching after that. We can do steroid injections. Again, I like to start with just the heel lift. Prefabricated orthotics, again, custom orthotics are always something that I'm talking to patients about. If the prefabricated orthotics work, stick with those. They just run out of support a little bit sooner. It's custom orthotics, I kind of equate it to glasses, right? You can go to Walmart and find something that's going to help you sometimes. Sometimes you need something that is specific to you. Other times you're able to utilize what is already been made. But those are all in the same idea, the night splint and a PT referral. And, I usually get to PRP at the end just because it takes a lot longer. Steroid injection typically feels better that next day, but you're kind of waiting to find out when the pain comes back in a week or two, is it done with less frequency and intensity? When the PRP injection hurts more in the beginning and you're still seeing benefits at week 4, 5, and 6, it's a lot slower process. And I typically get somebody new boot to just, it's painful for that first week, and just kind of let the body do its thing. Bunions, or HAV, which is just hallux abductor valgus. This is where the big toe swings over, and we got that kind of ball or knot at the inside of the foot. A lot of times it's shoe wear, right? I've had a lady come in before and say, "Why do my feet look like this?" And I didn't know for sure, but I said, "Bring in your shoes next time." She brought in her shoes, and all I did was sit them on the footrest. And she said, "Oh my goodness, my feet look like my shoes." And when we're wearing them for so long and doing so much in them, that doesn't surprise me at all, right? So you see when somebody's shoes come in, and then you can kind of see how narrow they are. Is their toe kind of doing this? Is it more tight and their toes are pulled up? Is that always the reason? No. But does that contribute? Yes. And one of the things I kind of wrote on here is, imagine going into the store, it's cold, and you want to get a pair of gloves, but when they give you a pair of gloves, it does this to your hands. You wouldn't keep it that way. You'd ask them for a bigger size or something that fits my foot. Differently, shoes are used a lot more for fashion, right? So we see something that we like, and I've done it, and I still do it. I'm going to cram my foot into that because I want to wear it, right? And so that whole thing of it would just be that can contribute to things. And sometimes patients don't want to change their shoe wear, and then at that point, we're talking surgery. The problem with that to me is that just means that most likely we're going to get the same problem later. Recurrence is a thing, right? It's not just something that once you get a bunion surgery, once you get a hammer toe surgery, that's good and gone at that point. If we're still going to continue to do the same things or use the same shoe wear the same way, most of the time, not most of the time, sometimes it comes back. I don't want to go that far to say most of the time, but it's just a lot easier to make adjustments. And if we need surgery, we use it, but continue to find what kind of fits our feet and our activity, because they're all different. Tendinitis. We get a lot of the peroneal tendinitis, which is on the outside or the lateral part of the foot. So it's going to be kind of the outside of your ankle, or the inside, which would be your PT tendinitis. I really like using bracing. So just ankle braces, honestly, that if you think about a wrist splint, right? So this motion hurts. I splint it. It doesn't move as much. I'm able to do this for 3 days, for 3 weeks. You take it off, and next thing you know, it feels better, right? It's not sharp anymore. It's sore. You've had to brace something. Ankle braces can do the same thing, where every time you go up, you're using your PT tendon. Every time you're pulling your foot up, you're using your peroneal tendon. And so by using a brace to tighten that area and support it in different ways that you can pull the straps, you actually take that motion out of the equation. Not completely, but enough that it can heal over some time, right? And some of it too is, I'll have the patient try it on in the office. Oh, my pain's gone, or I can do this motion now. Okay, so now I can get you to wear this for 2-3 weeks, and I can see it back. And now we can work on it, right? Because if I just hand somebody something and they don't know how to put it on, I show them and they still don't know how to put it on sometimes. But if you can show them how to use it, a lot of times somebody realizes why they're going to do it. And that just helps then. Because if I get them right to PT, same reasons for the Achilles and everything else. If stretching is going to aggravate it, then I want you to brace for a while. Bring the pain down, bring the inflammation down, oral steroids, injections, and then we'll get you to PT. So I use ankle braces all the time. The office is making fun of me because I've been wearing one. I was out playing with kids and, just rolled the ankle real quick. And it wasn't rolled, just pops it back. But if you just continue to walk on it that way, it's not going to get any better, right? Yeah. So I talk to patients all day about, I had a guy tell me today, I heard you know about shoes. And what I liked about it is just that somebody told him that whatever shoes that I told them worked. And so then they tell somebody else. And some of it is, it's not about the shoes as much as if your condition is at the ball of your foot or the forefoot, I'm going to try and get you some ultras or some topos. They have a wider toe box. If you're more just the walker or runner, probably Hoka or Brooks. That doesn't mean they fit every person or every activity, but these are just some shoes that I really try and get patients to go try. And some of it would be go to the store, walk around for a little while, go to these stores that let you take them home and bring them back. There are so many different variances of shoes that it used to be that, and maybe it's just me, but it seems like when we were told at 16 years old, you're size 11, you're just always an 11. Doesn't matter if it's Nike, doesn't matter if it's Keds, it doesn't matter what it is, right? But there's so many different versions now, and there's so many different models. I wear different size in Nike and just different models. And it changes things. It changes what bothers somebody's toe or what does this. And people come in saying, why is this? And I ask them, how new are these shoes? Oh, I got them a week ago. Lots of different things change based off of, did you get sized there, or did you just grab an 11 that you were an 11 in a Nike? And so some of it's about being sized and kind of how that goes. I also brought just some of the things that we'll utilize when, so this is your typical custom orthotic. This is a short length version. This is the shell that is really this is really what does the work. The rest, if you have a full length version, it's more about the softness of the top cover, and there's different reasons. Like these are really helpful in dress shoes or more low profile type shoes. Your athletic type shoes this is gonna help with sweat and things like that, but they don't have to be. And so there's different versions that can fit different shoe types that you wear. One of the things I will tell my patients though when I'm talking to them is they'll come back in and say, it doesn't fit my shoes. I didn't fit it for your shoes. I fit it for your foot, right? And so then at that point, jokingly, it's kind of a you problem, right? Because you want to control the foot. If I make it as narrow as your shoes are, that's part of the problem. And so I'm making it to control the foot and cup the heel. And at that point, there are going to be some shoes, I have them as well, that it sticks out on the side. I'm still being supported and I'm okay with that happening. Some patients aren't, but I'm not fitting them to shoes. If there's a specific shoe type that they want, we can talk about that. If it's for like a track shoe, like a spike, right? Or a soccer cleat, it's going to be different. I'm going to make it a little different, but I'm going to let them know they're not going to get the same control, right? And so they'll be supported, but it won't be controlled as much. And so there's just different parts of this, the carbon fiber versus the polypropylene. You'll get a little bit more time-wise with this, and different sized people and patients would change what you're going to do for that. And a lot of those can be worn, and the different top covers are also used where it's leather, Spanko, Plastizote. It just based off of, again, shoe type, but also patient's activity and different things like that. The orthotic is going to be more for the bottom of the foot or just support. So it's not going to be something that necessarily, it does affect the ankle, but it's once we get up to the ankle or collapse of the foot, we have some bigger type devices where somebody might have a Charcot foot or PTTD, which is posterior tibial tendon dysfunction. A lot of letters there, but essentially a collapse of the foot that won't stop. And some patients are not surgical candidates, or they are immobile or are not very mobile, or there's a lot of other issues. And so we're working on, is this the best way to do this, where you have to be off your foot for a certain amount of time, where we can get an AFO that really slows down that collapse, so you're not walking on your ankle bone. So they're used quite a bit, actually. I probably make 4 to 5 type AFOs probably a month. And then there's other versions where there's actual, so this is more, again, this is kind of, somebody's getting ulcerations or different things, and they're getting a full collapse, and we're trying to not allow that collapse to take place at the ankle. When this one is more of, there's instability of some kind where either there's lateral or medial ankle instability. There can be different, even just arthritic conditions, that now the ankle is allowed to stay in its neutral position and just come up and down and not side to side, so that you step on a rock and you get that shimmy of the foot, that doesn't hurt as much, right? Or at all. And so a lot of times these are used to kind of keep you locked in there, but also have the ability to use these. You can also, the other thing you can do with this is if somebody has foot drop, or they've lost some power of their dorsiflexion of their foot, you can make this so it'll assist and kind of pop their foot up for them, or at least just keep it at 90, because people call it foot drop, but it's also, you'll hear it as foot slap, because you'll hear somebody walking and their foot will just slap, and easily they can trip. I had a patient recently that she did that, her toes curled under and went down, and now she had a broken ankle. When we just didn't have an AFO that was supporting her enough, and she actually wasn't wearing it, but that's not the point. The idea of it slapping the ground, and it's just not giving you the support. So there's different AFOs that can be used at different times, even all the way to there are pro boots that the boot is up to here, up to the knee. Sorry for anybody who's not seeing, but it just keeps you locked in there. And it's for somebody that just continues to collapse and ulcerate and is not a great surgical candidate. There are people that are unable to essentially be without shoe wear, right? I mean, these hard surfaces are not forgiving. If somebody has a Charcot foot, which kind of has that rocker bottom look to it, you start to get some of those sores at the bottom. And so there's a lot of patients that will have to be in shoe wear for most of their day and the rest of their life. And then it always gets to surgery. I honestly do less surgery than in the podiatry world. And there's kind of a combination. There's some that kind of stay in the OR a lot, some that kind of are just clinicians, and some that kind of do in the middle. I'm kind of in the middle. I do less surgery. I really try and make adjustments for people. And some of it is, if I can teach you how to adjust that shoe or do it this way, then, because this is going to happen again. You know, when somebody comes back and says, my Achilles tendonitis is back, I know, right? But it's because you're up and you're moving and you're active. I mean, we're not going to keep everything away all the time. And so I like doing it that way. But there are plenty of surgical procedures that are a benefit. And I try and stay away from the ones that are just about aesthetically pleasing, right? So if there's pain, I'm your guy. If there's not pain, go find a plastic surgeon. That's where I'm at. Because now we're talking about a deformity. And so I did it once. And she kept telling me that the toes turn. And the idea that if you have zero pain, I promise you're going to have pain after surgery. So nobody's winning at that point besides the toe is straighter. And she actually had pain and swelling for the whole year, which I told her she wouldn't possibly have. But it didn't matter because all she thought about was the fact she didn't have pain to begin with. But if somebody has a 5 out of 10 pain and you bring it down to a 0 or a 1 or a 2, that patient's getting a benefit out of that, right? And we're teaching adjustments along the way. And so, you know, if like I said, if you have pain, I'm your guy. If not, we'll get you somewhere else where somebody wants to deal with that aftermath. But also with surgery, I'm big on, we're not going to fit it in between your time off of work and your next vacation. Then I'm put up against the time frame where sutures need to come out, pins need to come out. If there's anything that goes wrong with your pain, remember we constantly use these. So even after surgery, you're just using it so much that you can do the perfect surgery and somebody does one thing and now we've got a complication that's going to put us 2 weeks behind. And so for me, it's all about, if you know, one of my quotes all the time too is, it's not a hair appointment. You don't get to choose the time or day necessarily. We've got a few different days. Let's find out where you're at. And it's a commitment for the patient to not only show up, but also, you know, do what needs to be done afterwards so you can heal properly. You know, so a lot of times people think once it's done, and there's a lot more to that. Then we end up with other issues, and that's why we end up with hospital stays, in my opinion. But that's not the reason. And just getting back to life nice and slow, nice and easy. Too much, too soon. Next thing you know, we have just the same problem. And so, again, there's lots of different procedures that even a bunion, there's over 100 procedures somebody can do. There's a lot of them that are focused, and that's most of what the podiatry world does. But there's a lot of different things that can be done when it's needed. And I think that there's a lot of times, too, the same idea is there's a few docs at my office that do a lot different surgeries than I do, and they do them a lot more. And so I'll just let them know, Dr. Lundborg is great with those. Let's get you over there. He does those implants. And that's kind of where I go back to that team approach where I don't care who helps you, but if I know somebody who does, then I'll get you to them and see what we can do. And that's where I think the team approach really comes in, knowing that we're going to help our patient. And that just, you know, there's going to be another one, the next one, the next day, and all that. So just taking your time getting back to life. Otherwise, it just gets too fast. That's all I got.
So, you may have already answered this, but if someone is having foot issues, can they come directly to your office or do they have to have a referral from their primary care?
I apologize for making it sound like that earlier. No, it's just based off of insurance.
Okay.
And so like
okay.
Molina would need a referral.
Okay.
Blue Cross would not. Medicare would not. United Community would need a referral. So there's just certain ones that would need a referral, and it would need to come from their primary.
Okay.
Those ones specifically.
Okay. Perfect. Thank you for clarifying.
But a lot of times when I'm sending somebody out, if I'm wanting them to do something, the same idea would be, if I want that referral, most of the time I have to contact the primary to say, can we get this referral going so that gets that process started faster
Okay.
with some of the inner specialty referrals.
Okay. do you see people, like, is there an expedited process? I fall, break my foot, go to the emergency department, and then they would like refer me to you for aftercare or
Yeah.
like just
We,
kind of follow along?
yeah,
I'm struggling.
no, not at all. We have same day services.
Okay.
We've gone into, I recently was in a lot of the pediatric offices and just let them know, if you have an ingrown and if a pediatric physician, a primary knows how to do them, wants to do them. But if you don't, we have same day where we can see that child that day and get them taken care of. If they can't that day, we can get them going on some antibiotics if needed, and we can see them. The same thing with a fracture or a wound, different things like that. So we'll have somebody that same day and or the next day go into the ER, show over their papers, and they've got a referral from the ER right to our
Okay.
office.
Oh, perfect.
Yeah.
Awesome. That's good to know.